Thank you, Teresa, for the wonderful introduction. So my role today is to introduce the topic that we're going to focus on and to tell you about how we came to be studying prevention of preeclampsia. The Obstetric Fetal Pharmacology Research Centers are a group of centers that are funded by NICHD specifically to look at improving the database for the use of medications during pregnancy. And we were delighted last year to have been selected as one of 3 sites that are going to focus on this important problem. So this is a quote from one of Kate's articles, and it really speaks to why we need these obstetric fetal pharmacology centers. Pregnant women are really the last therapeutic orphans because, as you can imagine, people are reluctant to include pregnant women in drug studies. So if you're a pregnant woman who has a disease that uses or that for which drugs are required as a mainstay of treatment, the data to inform decision-making around the use of that medication in pregnancy probably doesn't exist. So again, for the last 10 years, these OPRC centers have existed, and we were fortunate enough to be chosen as one last year. The mission of these centers and of NICHD, the NIH institute that funds child health and human development studies, the mission of that institute is displayed here. And the importance is really looking at how do we improve the efficacy and the safety of drugs that are used in pregnant women, and how do we get groups to come together in multidisciplinary teams to address this complex physiologic, pharmacologic, genetic, how do we address these issues comprehensively? So an interesting development occurred in the CDC that I think underlines the importance again of research with pregnant women who must take medications. So the important point here, and the one that we used for a recent editorial, was pregnant women get sick and sick women get pregnant. So the Center for Disease Control published this initiative, Treating for Two, and the agenda here is to move us away from the dogma that medications should be avoided at all costs in pregnancy to a research agenda where we're looking at how do we use medications most effectively to treat disease in pregnancy so that we can get the best outcomes for the mother and the fetus. So again, away from medications shouldn't be used in pregnancy too. For women who need medications to treat diseases in pregnancy, how do we obtain data to support the best kinds of decision making? So within these OPRCs, our site at Northwestern proposed a study called Optimum, and we're delighted that we're going to be ready to initiate this study in about the next 2 weeks. This study is a study of optimizing SSRI antidepressant treatment during pregnancy. So for pregnant women who are depressed who take these medications, specifically Prozac, which is fluoxetine, Celexa, which is citalopram or Lexapro, or Zoloft, which is sertraline, for women who take those medications in pregnancy, we don't really know how pregnancy physiology affects the concentrations and efficacy of these medications across pregnancy. So we proposed a study in which we're evaluating the concentrations of those medications sequentially across pregnancy and looking at the pharmacogenetic profiles so we can determine how best to keep these women well in pregnancy by looking carefully at dosing. Just to illustrate what we're looking at briefly, this graphic is one from a very old study I did in the 90s about tricyclic antidepressants. And what you're looking at are a series of individual patients and the doses that were required of their antidepressant drugs, again, tricyclics across pregnancy. And what you can see is a pattern in which at about 20 weeks gestation, the doses that they needed started going up. And in fact, in the 3rd trimester, the doses that they needed were dramatically high compared to the earlier part of pregnancy. We now know these drugs are metabolized by a cytochrome that's induced in pregnancy, and that the doses of medication needed are much higher, and in fact, the levels, the concentrations of these drugs in the 3rd trimester even on those higher doses, were generally the same or less than third trimester. So in this study we call Optimum, what we're trying to do is do the same thing for the more commonly used SSRI antidepressants. So the second study that was proposed was one of buprenorphine, which is an opioid drug that is used to treat pain or used to maintain women who were addicted to opioid medications during pregnancy and in non-pregnancy as well. That study is not yet up and running. The third study is the one that we're going to focus on today, and it has already gone through some phase 1 testing. And we have this particular protocol available up and running at our site here at Northwestern. And again, we're delighted to be able to bring it to our patients here. And Kate is going to tell us about this study, Preeclampsia of Pregnancy, the Path Toward Prevention. So we like a little bit of alliteration. Kate.
Thank you both to Kathy as well as Teresa. Thank you for that introduction. So the order of which I'm going to be speaking today will first define preeclampsia and eclampsia, and then I'm going to talk about the rationale for the preventive treatment of recurrent preeclampsia with Pravastatin. And when I tell people, even in my own field, that there's a study using Pravastatin to prevent preeclampsia, people say, a statin in pregnancy? Basically that's a category X drug. And I'll go through all the background as to why, in fact, it actually may be an ideal drug to use in pregnancy. I'll talk briefly about why Pravastatin versus the other statins, and then I'll go over the results of the first part of the clinical trial protocol that was published recently in the American Journal of OB-GYN. And then I'll talk about how it's been modified for our current protocol that we're using now and in actively enrolling patients. So eclampsia was first described way back in the 5th century BC by Hippocrates. And the word eclampsia is actually a derivation of the ancient Greek word for lightning. And the reason why they chose lightning is because basically eclampsia occurs out of the blue. Suddenly, a woman's been pregnant, she's approaching term, and suddenly everything dramatically changes. In people who we just never expected this to happen to, and eclampsia is an eclamptic seizure. It is the seizure, the final, ultimate effects of worsening preeclampsia is an eclamptic seizure. So what is preeclampsia and eclampsia? For those of us who are in obstetrics and gynecology, you don't need to explain this. This is truly our bread and butter. We deal with this day in and day out. For the rest of us who might have been Downton Abbey fans, we actually were very familiar with a situation when Lady Sybil, in childbirth, ultimately died of an eclamptic seizure. And being a skeptic that I am about how medical conditions are portrayed on television, I was actually very surprised how realistic and how accurate not only did they portray the disease process itself, but also the understanding of the disease at that time. She clearly had high blood pressure. They were able to ascertain that she was spilling large amounts of protein in her urine. She was very swollen, edematous extremities. She ultimately evolved to a state of mental confusion, which then culminated in a seizure and the eclampsia portion of preeclampsia, and then she died. What they weren't able to know and understand, because our ability to detect this is clearly a bit more sophisticated these days, is that preeclampsia also can involve abnormal liver enzymes, low platelets, hemolysis of red blood cells, renal failure, pulmonary edema, and the symptoms that usually get portrayed, which they would have recognized, was the edema, visual changes, headache, nausea and vomiting, epigastric discomfort because of the swelling of the liver with a subcapsular hematoma. The other impact is on the fetus. There are placental microinfarcts, which leads to placental insufficiency, intrauterine growth restriction, and if left in utero with a continuing pregnancy, the potential for fetal demise. The other significant effects are the impact on prematurity. When a woman develops preeclampsia long before term, we're faced with the need for both her protection as well as the fetal protection to deliver the woman prematurely. And so we have all then the consequences of a baby that is born preterm. Just a few facts and definitions. Hypertensive disorders complicate approximately 10% of all pregnancies. Preeclampsia develops in 3.9% of all pregnancies. So there's a difference between hypertension and preeclampsia, and I'll define that in a little bit. The incidence of preeclampsia in the United States has actually increased by 25% over the past 2 decades. And the reasons for that have to the well-known, increase in obesity, and with that, the concomitant increase in diabetes and chronic hypertension, which are all major risk factors for the development of preeclampsia. Hypertensive disorders affect 16%, are responsible for 16% of maternal deaths. It's estimated that the deaths in 2013 were actually reduced compared to the deaths in 1990. It's also responsible for 12% of the premature births. And the WHO estimated that the impact of maternal hypertension on both maternal and perinatal on fetal deaths worldwide were between 50,000 and 60,000 deaths per year. So this is a significant, significant problem affecting moms who are pregnant. I'd mentioned before, there's a difference between gestational hypertension, chronic hypertension, preeclampsia, and I just wanted to define them. Gestational hypertension is the elevation of blood pressure above 140/90 after mid-pregnancy without preeclampsia or eclampsia. So this is women who are normal, who have been normotensive before they become pregnant, who are normotensive in the first part of their pregnancy, and then at some point after 20 weeks, develop elevated blood pressure without the features of preeclampsia. Chronic hypertension is the disease that predates pregnancy. So it's women who either have chronic hypertension before they become pregnant or have manifestations of elevated blood pressure before 20 weeks. Preeclampsia and eclampsia is a particular subset of this, in which the blood pressure is elevated, either 140/90 on 2 occasions or even higher level of 160/110, plus the features of either proteinuria, decreased platelets, renal abnormalities, abnormal liver function tests, and that then elevates you to the diagnosis of preeclampsia. Preeclampsia can also be superimposed on women who have chronic or gestational hypertension. So you can start off with either hypertension before you become pregnant, or you can develop chronic hypertension, and then over the course of your pregnancy, begin to show features of preeclampsia. So it's a continuum, it's an evolution. There are certain risk factors. Preeclampsia occurs much more commonly in first-time moms. It also has an ethnic predisposition. African Americans are much more likely to develop preeclampsia than Hispanics, and even less so Caucasians. It is absolutely related to the gestational number. Twins, triplets, quads are much more likely to have preeclampsia than moms who are carrying singletons. Maternal obesity is a risk factor, as I've mentioned before. Women as they age have an increased risk of preeclampsia. And anybody who has any kind of underlying disease that affects your blood vessels, the vascular endothelium, such as diabetes or any autoimmune disease, plus others, are much more likely to develop preeclampsia than somebody who starts out being healthy. What's odd is that it affects first-time fathers. So the moms of, let's see, if I have a baby, I'm much more likely first time with this father of my baby to have preeclampsia. Second time around, I may not have it, but if I change partners and somebody else fathers that baby, my risk of developing preeclampsia in that pregnancy suddenly goes back to the original risk of a new father. So there's something immunological going on between the difference in antibodies that are, the antigens that are present in the fetal placenta that can affect the incidence of preeclampsia. And also, as we begin summer, we are clearly seeing our seasonal increase in preeclampsia. Preeclampsia is much more common in the summertime. So how do we treat preeclampsia? Besides actually decreasing the blood pressure, what is our primary treatment for preeclampsia? And unfortunately, the only definitive treatment for preeclampsia is delivery of the fetus and the placenta. Now, that doesn't stop cold turkey the process, but it is the first step in returning to normal and to, correcting these significant changes that are taking place in the mom. But the question becomes, what if we could prevent preeclampsia from developing in the first place? And to that question, that is the basis of the study that we are currently doing. So the question I go back to, why a statin in pregnancy? Why are we using Pravastatin as a prevention therapy in pregnancy? Pravastatin, being a statin, is indicated for the lowering of cholesterol, of lipid abnormalities. The symptoms of elevated lipids are clearly different than preeclampsia and pregnancy. I mean, we are talking about two different disease manifestations. However, what is fascinating is that the underlying etiology, the cause for both of them, has profound similarities. Both of them are dependent upon endothelial, the lining of the blood vessels, dysfunction, and inflammation. This is a common physiological abnormality that affects both diseases. So when you have atherosclerosis, what occurs is you initially get lipid infiltration of the vascular endothelium, and it initiates an inflammatory process within the vessel wall. You get all sorts of different cytokines and growth factors that get released that stimulate the influx of macrophages, and then you just get this further escalation and cascade effect of localized inflammation within the vascular endothelium. And the evolution of that is dependent upon the balance of both inflammatory processes, which lead to worsening atherosclerosis, and anti-inflammatory processes. What's been shown is that statins not only have an effect on lowering lipids, but they also have a fundamental ability to reduce and to alter this inflammatory process. They're able to inhibit T-cell activation, and they promote the release of anti-inflammatory compounds, and they upregulate enzymes that are able to suppress the inflammation. So although people may be thinking that they're taking statins for the prevention, for the lowering of lipids, what they're actually having is a secondary benefit of reducing the inflammation within their vascular tree. And these are just histological pictures showing the similarity between these are images of the spiral arteries in preeclamptic placentas showing thrombus and inflammation, an inflammatory response within them, and comparing the similarity to a coronary artery that has atherosclerosis. So how does this then relate to preeclampsia? Where does the inflammation originate in the preeclampsia story? So in this picture, this diagram, what we have over here, just to kind of explain what's going on here, this is a chorionic villi that's originating from the fetus in the placenta. So this entire diagram is an image of is a cut through of the maternal placenta. And you have a chorionic villi here. What you have are the spiral arteries. These are the maternal vessels that feed the endothelium, that then support, that provide the maternal blood, that then is in exchange, the exchange of nutrients and oxygen, as well as waste products from the fetus. And so this is the spiral artery that feeds the decidua, the placenta. And then this is just a vein going backwards. And what you can see here, this is the trophoblastic cells from the fetus, fetal origin again, that are able to invade and replace the lining. It's like they're covering that lining of the spiral arteries in that placenta. And this is just another picture here. What happens is, as the placenta develops, you get migration of the trophoblast, and this is the normal picture here, up those spiral arteries. And what it allows for is a widening of those spiral arteries. And if you think about a flow picture, when you've got a river, when it's high in the mountains and it's narrow, it rushes down with an incredible amount of force. But as that river opens up and widens, it's able to carry much larger volumes of water, but without the force, without the speed, and it just kind of slows down in that delta. And that's essentially what happens in the placenta. This whole process enables that high pressure spiral artery to deliver blood to the chorionic villi in a much slower, calmer environment so that the exchange can appropriately take place. And this on the other side is an image, I mean, it still shows a little bit of widening, but you don't see any of the invasion of the trophoblast up those spiral arteries, and you don't see the ability of this abnormal placental here to deliver the blood flow in a calm environment that a normal placenta is able to do. So, the failure of spiral artery remodeling in a placenta that is destined to cause preeclampsia in that mom makes for a high-pressure, forceful bombardment of that chorionic villi. And what happens is those villi don't like it. It is being constantly hit, and it causes inflammation. And you get release of localized inflammatory compounds, enzymes, markers from this placenta. And that's the first stage of the development of preeclampsia. What then happens is you have, in this defective defective placenta, you get decreased factors that are what we call angiogenic. It's the good markers. It's the ones that reduce inflammation, and you get an increased production of the pro-inflammatory markers. So placental growth, and I'm mentioning these because these markers are actually followed and analyzed in the study with Pravastatin. And what you find is that in a woman who is going to become preeclamptic, in the weeks before she actually manifests these conditions, all these symptoms that we're used to seeing, you actually get significant increases in these anti-angiogenic, the pro-inflammatory markers of S-FLT and S-ENG. So these factors plus other markers of inflammation contribute to the generalized endothelial injury of blood vessels both within the placenta, and then they get dispersed throughout the whole body, and they cause generalized inflammation within the rest of the body systemically. So you get placental vascular injury that causes generalized inflammation at distant sites, and it is these changes here that produce the symptoms, the signs and symptoms of preeclampsia. So it's got this two-stage development where you're early in pregnancy, unbeknownst to everybody, you have this physiological changes that later lead to the manifestations of preeclampsia at some point over the course of the pregnancy. Sometimes it occurs at term, sometimes it can occur much more severely earlier on in pregnancy. So what have we looked at? What other anti-inflammatory medications have looked at? We've tried without success to look at increased doses of calcium, fish oil, antihypertensives, vitamin C and E, and none of them worked. The only one that in a meta-analysis looked like it might have a minimum effect is actually aspirin. So currently we are using a baby aspirin once daily in anybody who we think has a risk factor for developing preeclampsia. It at least helps a little bit. But you have to start it very early on because you have to have its effect on those inflammatory changes when they're beginning early in pregnancy. Before we used Pravastatin, we looked at animal data. We can actually there's actually a mouse preeclamptic model that overexpresses S-FLT, which is the inflammatory marker, and this mouse develops all the signs and symptoms of preeclampsia with high blood pressure and proteinuria, changes in the kidney, placental hypoxia, and growth restriction of the pups. And we found by giving Pravastatin, you're actually able to reverse both all of those symptoms as well as the inflammatory markers in the mouse. So with that background, the question is, which of the statins is the best? Because they've looked at multiple different statins. And it turns out that Pravastatin is the most water-soluble, and as a result, the less likely to cross the placenta. And this is data from a dual perfused placental study where they actually take part of the placenta and they infuse blood into it from the mom, and then they have blood coming from the fetus. And they're able to see, what's really interesting is that when you look at fetal to maternal blood flow across it for Pravastatin, it's actually favored to move to the mom, and it's harder to get Pravastatin across the placenta from the mom into the fetus. And so Pravastatin was chosen because it appeared to be the most fetal sparing of the different statins. So the question is, how do you study a statin in pregnancy? It's a category X. I mean, and everybody has known statins are category X. Question is, why was it a category X? Why did it get that nomenclature? And that's because to become a category X, which by the way is in the process of, we're no longer using those, but this is a carryover in terms of our mindset. Not only there are two aspects for that designation. One is a drug that has clearly been shown to be teratogenic and should not be used in pregnancy because of the risks to the fetus. The other is that it doesn't seem to have any beneficial effect in pregnancy. So if it's not going to help you, why should you even take it? And this is why birth control pills have been called category X drugs. They don't cause birth defects. Birth control pills do not, a mom who becomes pregnant because she hasn't been taking her birth control pills properly, or it's not the appropriate dose, is not at risk of having a congenitally abnormal fetus. It's considered category X though, because once you're pregnant, you don't really need birth control pills. There's really not a reason to be taking a birth control pill once you're pregnant. So that's how it got its category X designation. So statins got it because there is no benefit. I mean, cholesterol goes up significantly in pregnancy because it is the precursor for all the development of all of the hormones that we need in pregnancy. They then looked at the post-marketing surveillance because, as Kathy said, sick women get pregnant. Women who are on statins do inadvertently become pregnant. And clearly, in looking at a number of studies, there were no untoward effects on the fetus. There was no increased risk of teratogenicity. And so before they got the study, they were able to get, and they had to get, a IND, investigational new drug category to look at statins in pregnancy. So the first phase of this study, the use of Pravastatin is a combined phase 1 and phase 2 study. And what is that? What that means is we're looking not only, a phase 1 study is when you're doing a pharmacokinetic study. In other words, when you give a drug to somebody, what are the resulting concentrations? How is the drug cleared? What does it do in the body? Just to kind of better understand how your body distributes and then metabolizes and clears this drug. A phase 2 study is what's the appropriate dose? In other words, how much of this drug do I need to get the desired effect? So this is a phase 1 and phase 2 study where we are both within the same study looking at both pharmacokinetics and then dose escalating over the course of at least 2 phases, if not possibly a third. So they have completed the first phase with a 10 milligram dose of Pravastatin. We are currently looking at the second phase, which is a 20 milligram dose of Pravastatin. Just like with using the aspirin, because this is a process that begins very early, we have to start it between 12 and 16 weeks. And it's a randomized controlled study where people are randomized either to Pravastatin or placebo. When you're trying to see if the drug has effect, you have to find the population that's most at risk. So people that are included in this study are women who previously had a severe episode of severe preeclampsia that precipitated delivery prior to 34 weeks. So we know that this population in subsequent pregnancies has a 30% risk of having another baby, having another situation of preeclampsia. Certain women are excluded, and this is a litany of people who have an exaggerated risk of developing preeclampsia. So we wanted to prevent them so we wanted to look simply at relatively healthy women who are at risk of having it a second time. Included in the study is 3 pharmacokinetic studies in the second trimester, in the third trimester, and then distant postpartum. And it's a paired study so that women will act as their own control. So you'll compare what their pharmacokinetic parameters are postpartum in the non-pregnant state with what was going on while they were pregnant. And the assays are looking at both pravastatin and its metabolite. And then at delivery, we're also looking at maternal venous blood, as well as the umbilical cord venous and arterial samples to see how much is it crossing the placenta and what kind of fetal exposure they're getting. They are also analyzing those markers, those pro-inflammatory and anti-inflammatory markers that we talked about at 3 different stages over the course of the pregnancy to see what the impact of pravastatin is on these concentrations. So in this study, this is a study flow chart. There were 10 people that were randomized to placebo, 11 people initially to the pravastatin arm, and then 1 person withdrew, so that ultimately there were 10 people in each arm. What they found is that these groups were relatively very similar. You can see the incidence of chronic hypertension actually was a little bit higher in the women with pravastatin. And the use of low-dose aspirin was actually kind of in its infancy there. And so, whereas now you might find most people on a low-dose aspirin, at this time only 5 women out of the 20 women randomized were. When you look at adverse events, the ones that you're not surprised to see, I mean, heartburn, every pregnant woman gets heartburn. The musculoskeletal pain was a little bit more common in the women who took the pravastatin, and that's a very common side effect from statin use. In terms of the serious adverse effects, events, they were pretty much similar across the board, and none of them really seemed to be related to the statin use. In terms of maternal outcomes, this is where it gets interesting. If you look at the incidence of the recurrence of both mild and severe preeclampsia, in the placebo arm, 4 out of the 10 women developed it, so it's about a 40% incidence. And as I said before, you would expect approximately 30% to get a recurrence. Now, again, this is not powered for efficacy, but it's really interesting to see in the pravastatin arm, not a single woman developed preeclampsia. If you look at indicated preterm delivery, less than 37 weeks, 5 of the women in the placebo arm were delivered early, only 1 in the pravastatin. Now, there could be other reasons for a preterm delivery, but it's clearly there's a difference between these 2. Gestational age. All these women had to be in their first pregnancy before 34 weeks. What you can sort of see in the women that were in the pravastatin arm, there tends to be, and like I said, none of this is statistically significant, an increase in the duration. They stayed pregnant longer subsequently compared to the people on placebo. If you look at their lipid profiles, as you would expect, there's a lowering of lipids in the mom. In terms of the fetus, there wasn't any lipid lowering effect at all in the fetus. If you look at the pharmacokinetics, because there were those PK studies done at 3 different stages, what you're able to see, and none of this is statistically significant, so this is just a trend, but what you're able to see is that the concentrations in pregnancy were somewhat lower than the concentrations postpartum, and the area under the curve, so how much concentration time curve, was also lower in pregnancy compared to postpartum. And the reason for this is presumed to be because pravastatin distributes to total body water, or almost, and body water in the pregnant women are wetter. Their total body water goes up by 30 to 40%. And so pravastatin has a larger volume to distribute in. What you also see is that there's a tendency to have increased clearance in pregnancy, as well as when you look at the renal clearance, there's an increased clearance in pregnancy renally compared to postpartum, and that's because renal clearance also goes up in general by 40% in pregnancy. When you looked at, and this is a busy slide, the gist of this slide is if you look at maternal concentrations to fetal concentrations, they hardly ever saw a drug in the fetus. When you looked at these markers, what do you see? You see the S-FLT. Now this is the pro-inflammatory, this is one of the pro-inflammatory markers, S-FLT1. And you see in the placebo group, that there tends to be the higher occurrence was in the women not taking pravastatin compared to those on pravastatin. When you look at SN, which is also the bad pro-inflammatory marker, once again, you see a preponderance of women on pravastatin having somewhat lower. And again, this is not statistically significant. It's just an interesting finding. The good ones, the ones that are anti-inflammatory or placental growth factor. So this is at randomization. The placebo is the darker group on the left, and you see that they can be somewhat relatively similar. The good markers have a tendency to go up in the moms that were taking pravastatin. So this is the next phase. As I said before, this is just the pilot study. Both phase 1 and phase 2, and possibly a phase 3 when we up the dose to perhaps 40 milligrams of pravastatin, are all the pilot studies that will then be used to put together the big phase 3 safety and efficacy study looking at pravastatin for the prevention of preeclampsia, that will be then sponsored and run by the MFM network. So there are probably close to almost 24 network sites across the country. Northwestern is a very significant player in that network. We are members of, and we have been for a very long time, members of the MFMU network. And they will be the organization that runs the phase 3 safety and efficacy. But the data from this study will be used to power and drive and the design of that phase 3. What we're doing, the only things that are different in our current protocol is that we're using a 20 milligram dose. And because the cutoff initially had been 33 and 6, it was harder to enroll people because we have a tendency to try desperately to keep people to 34 and 0. And so once somebody reaches 34 and 0, we then induce labor or we deliver them the next day, if they have severe features. And so all these people, there were a good number of women that were not qualified because they missed it by 1 or 2 days, that cutoff. So we've extended the cutoff to 34 and 6 by 1 week. And this is basically our design for our current protocol. If you have any patients, if you know of anybody, or if you're interested in learning more about this study, you can call. This is the number for the Asher Center. And our current study coordinator is Sarah Lynch, and this is her email address. And I'm done. Are there any questions?